Divaka Perera and Mike Gibson coming to you live from ACC 2023, and we're talking about the relationship between myocardial viability, performance of PCI, and outcomes. The revived BCIS2 study. Talk to us a little bit about what you did.
Mike, thanks for doing this interview. So you recall that we presented the revived data in August last year, and it showed that there was no incremental benefit of PCI above medical therapy when the population was considered as a whole, both in terms of clinical events and LV recovery. But what we didn't know at that time was how the amount of viability and the viability characterization in these patients might affect those outcomes. Because, as you know, Stitch and Stitcher's viability suggested that it didn't have any role in predicting the effect of revascularization, and also that if you had LV recovery, that didn't affect outcome either. That's the state of play from Stitch. So we set out to characterize these patients via core lab analysis of CMRs and dobutamine stress echoes in a continuous way. So patients weren't categorized in a binary way, but we characterized the amount of dysfunctional but viable myocardium as well as scar in a continuous way, and looked at the impact between that and death or heart failure hospitalization, the primary outcome, and LV recovery at 6 months, which was the secondary outcome. And of course, if we did show a difference, we then wanted to find out whether knowing the viability status allowed you to pick patients who might benefit from PCI.
Mm-hmm.
That was the premise of the study.
And what did you find?
Well, interestingly, we found that viability, if you characterize that as dysfunctional but viable segments, didn't actually predict the occurrence of death or heart failure hospitalization or LV recovery, on the other hand. But if you looked at scar volume as a proportion of total LV myocardium, that was really powerfully predictive, very powerfully predictive of death or heart failure hospitalization and LV recovery. And interestingly, the predictive ability remained even when you controlled for baseline LV EF. Conversely, if you corrected for scar, baseline LVEF itself was no longer predictive, which is our current standard of care in terms of risk prediction. But when you looked at it in terms of treatment assignment and the interaction with treatment assignment, there was no difference, whether you characterize them by viability status or not. So the initial results that we found and presented last year hold even when you characterize for viability. And the final piece of the puzzle was, if you do have LV recovery at 6 months, does it augur a good prognosis? And yes, definitely, it does. So it sort of confirmed the biology that we think we understand.
Yeah, scar is fascinating. I mean, it's not just that you have an area that's not squeezing and functioning. It's also pro-arrhythmic, where you have dead tissue against living tissue, number one. And it's more than just that. It's also the complexity of the scar. If you have a very serpiginous scar, you may have even more dead tissue against viable tissue and worse outcomes. At least that's what we've seen in MI. So, I think so many people focus on viability. It's taken a couple of hits, that hypothesis, hasn't it? I mean, was the hypothesis wrong? Or were the measurements wrong? Or were we just barking up the wrong tree?
Yeah, it's interesting. Most people use viability in a way that reflects the underlying theory of hibernation, that we link benefit to recovery of LV function. Whereas, as you've just implied, it's much more complex than that, and it's more likely to do with arrhythmia. Yes. So we've just shown that scar volume as a primary measure really closely relates to it, and actually probably should be integrated into our risk prediction much more than it is now. Right. But then you went on to talk about something really interesting, which we're also looking at, which is the scar heterogeneity.
Correct.
The skew of scar and how that scar interacts with the surrounding healthy or even ischemic myocardium. So we're doing scar analysis as well, but I don't have that to share with you right now. that'll
I
be
bet it'll turn out positive. We found it to be positive. So speckling heterogeneity of scars is important, particularly like in hokum. I bet it is here. And I bet you'll see some relationships between complexity and outcomes as well. Well, exciting stuff, you know, another great paradigm bites the dust. The data, the data always wins. Well, Divaka, thank you so much for joining us. Fascinating stuff, and look forward to seeing your future results.
Thank you, Mike.